Okay. Again, my name is Mary. I am one of the nurse practitioners here, and our topic today is ethics. So the big disclosure is I am not an ethics professional nor a scholar of ethics. It's just something that I feel like that I've encountered a lot in my career. I think is interesting in terms of continuing on current literature and seeing what different resources we have available. So the objectives here today are really to kind of review just the basics and the foundation of biomedical ethics, and then review some of the ethical considerations that come up in cardiology specifically. There are kind of 4 principles of biomedical ethics. There are many more than this, but these are kind of the pillars that really inform kind of our day-to-day decision-making and actions. Autonomy, beneficence, non-maleficence, and justice. So autonomy is really the idea that informed choices of a capable or capacitated patient to accept or refuse treatment should be respected. And this really also includes the ideas of disclosure, informed consent, and shared medical decision-making. And beneficence is acting in the best interest of the patient. Non-maleficence is the idea that we're here to prevent harm, or if harm is unavoidable, to minimize risk. And justice is the principle that we should think about the equitable distributions of benefits and burdens to society and our communities. So there are many different codes of ethics found in medicine. The American Medical Association and the American Nurses Association both have pretty comprehensive and lengthy codes of ethics that really span kind of all of the topics you might expect. Specifically, the West Virginia Boards of Medicine and Nursing, I was not able to find a specific code of ethics that was available on their websites. The Board of Nursing did direct to the American Nurses Association Code of Ethics. And then interestingly, the American College of Cardiology, their code of ethics seemed a little bit more like a code of conduct when I was reading it and reviewing it. And there's an interesting line that I thought I would read for us. They say that a member shall not discriminate on the basis of sex, gender identity, race, color, national origin, sexual orientation, or other basis that would constitute illegal discrimination. So I thought it was interesting that they brought legality and the law into what they thought was ethical behavior for their physicians. Okay. And doing some reading in particular for this talk today, Karen Joint is a physician and researcher at Brigham and Women's Hospital in Boston. And this is a few years old now, but I have the idea that it's probably still just as relevant. And she said that cardiovascular medicine is the clinical area where there is the most thorough documentation of racial and ethnic disparities in access to care, as well as sex-based, economic, and geographic disparities. So that kind of highlights why all of this is really relevant to cardiovascular medicine and why it would be important to include it in our Project ECHO. Specifics in cardiology or specific ethical considerations, kind of the big one you always think about is transplant or xenotransplant, and certainly organ donation on the flip side of that. End of life, advances in technology with new devices and implants, mechanical circulatory support, including LVAD therapy, and cost, access, and race. And many of these things are becoming more important as our population ages and people are living longer. And I chose just a few of these things to talk about today to kind of dive a little bit more deeply into. I tried to pick topics that were both relevant for both cardiology practice, but also primary care and internal medicine. First one is drug cost. So I think there isn't anybody who doesn't think, or at least have had some interaction with price of drugs, whether that's from, you know, their pressure to prescribe, or more commonly patients saying that they're unable to afford medications. A study that was published in Circulation in 2019 estimated that 1 in 8 patients, or about 13%, with known atherosclerotic cardiovascular disease reported non-adherence to medications because of cost. We certainly know that out-of-pocket costs for our patients vary, and the decisions that are made both by prescribers and by payers or insurers are really made with imperfect data. So we treat unique individuals with complex medical histories, and most of the research that is done in clinical trials is conducted on relatively homogeneous populations. You know, when you get to the end and you're reading the conclusions, and there's always discussion of generalizability of this data, and can you extrapolate the data or the information and the findings from that study and that particular medication to your patient or your patient population. Cost effectiveness data is not always available for newer medications. Cost effectiveness data is not required by the FDA for drug approval, and it is a it is a post-marketing kind of agreement that pharmaceutical companies will do. They don't always fulfill this, but a lot of this research is done elsewhere. And then you can also consider that the cost-benefit analysis is really incomplete for medications in terms of quality of life. It's something that's not always measured, and most research is done on more of the hard outcomes of morbidity and mortality. So what is our ethical obligation as healthcare providers and prescribers? There was an argument that was published in the AMA Journal of Ethics that said that all physicians, and we can extrapolate that to PAs and nurse practitioners, as well as our pharmacists, are obligated to protect patients from financial harms and to advocate for policy change and fair and prudent resource allocation. And this really kind of applies the principles of non-maleficence and justice. And this is pretty broad speaking, and this is you know, much outside of just practicing in the clinic. This is looking at policy level and how decisions are made overall. So how do we make more of those decisions about prescribing what are or what can be very expensive medications? So what about, and I'm sorry, I had nice transitions that aren't working. So what about when a patient says, I can't afford my medication? What are our options? What can we do? We can proceed to prescribe that and recommend that they take it despite cost. Should we compromise the standard of care? Or should we decline to provide care at all, saying that, you know, if we can't prescribe and offer the therapies that we feel are best, that maybe we just won't treat the patient at all? And the principles that are really at play in this situation are autonomy. So the patient does have the right to say yes or no, I do want to, or I do not want to take that medication. Again, this should be informed. They should be informed of the risks and benefits of both that therapy as well as alternatives. Beneficence, thinking of how we can truly best keep their best interests in the forefront, and then to do no harm. So what are things you can actually do in the day-to-day? So, you know, you're sitting and talking with someone. Well, it's really easy to say, yeah, physicians and nurse practitioners and PAs and the like should be advocating and should be trying to change policy and change pharma practices. But you still have to see the patient who's going to tell you, I can't afford to take that. So identifying resources both inside and outside of the organization that you work for, whether that's your own internal resources or charity care that's available, whether it's utilizing a social worker to help access insurance options, or if it's enrolling a patient in assistance program through a pharmaceutical company. The other thing to consider is a reasonable referral possible. Is there an institution that you know that does have some charity care that can take on patients who can't necessarily afford all of the care that they need a little bit better than your own facility? And if the answer to these is really no, then there's a lot of kind of discussion when I was reading and doing more of this specific research for this talk, that lowering the standard of the care that you're giving might still be in the best interest of that patient. And that would truly be in the case where there's not a better place to refer them, or that the quality of care that they're able to get from you, even if that is different than what the standard practice is, or the continuity of care would still be serving the patient best. And the big thing with this is document. Document that you had the discussion with the patient, again, about the risks, about the alternatives, that they're making an informed decision, and that there's a reason that you're perhaps not following what the standard might be. And another way to even think about this more proactively is have an upfront discussion about cost. Let your patients know if they go to the pharmacy and they can't afford it. Sometimes it'll be 2 months and you'll assume, I didn't hear anything. I thought they would have picked up the medication and started taking it, and yet they just don't tell you. Right. So the next kind of thing I thought we could talk about are ICDs. It's something, it kind of, again, crosses the boundaries between cardiology and primary care and internal medicine. And by definition, ICDs, or implantable cardiodefibrillators, treat lethal durations of bradycardia and tachyarrhythmias. So this was a quote that I thought was a little bit aggressive, but I also thought it illustrated the point well, where advances in medicine have the effect of ever-increasing numbers of people who live with chronic, debilitating, and progressive illness that will ultimately result in death. So the Heart Rhythm Society has put out a consensus statement trying to help and guide some of the decision-making around this, with this idea in mind. We know that ICDs are seen in sicker and older patients. And there was a study in particular that suggested that up to maybe even 20% of patients receive what they consider to be a painful and distressing shock near the end of life. So, and really kind of delving into the ethical issues that might be seen from the healthcare professional point of view, there's the idea of withdrawing of a therapy versus euthanasia or assisted suicide. And this is, there were two ways that some of the discussion I read kind of broke this down. One is thinking about the intent, and then one is thinking about what is the ultimate cause of death. So the intent, if a patient wishes to have their ICD turned off, or if it's a discussion you're having near end of life, the intent is truly to do no harm, to prevent a painful intervention, and to respect autonomy. And cause of death is the other kind of big point that helps to differentiate between withdrawal of ICD therapy or euthanasia or assisted suicide. And with both of these things, there's a consequence to the action. So withdrawing therapy means that you're no longer providing the shock that would happen with a lethal arrhythmia. But by stopping that, or by taking that away, a patient would be dying of their underlying condition. or acute condition. Where euthanasia or assisted suicide are also actions, but those methods and actions are provided by a healthcare provider. The other kind of ethical debate, and I've even seen this kind of play out in my experience, is the idea of discontinuing a pacemaker versus an ICD. So there are folks who have both functions, or there are folks who are dependent on a pacemaker. And at times, certainly, it can be a difficult thing when you're discussing one versus the other. So there's a lot of divisiveness about this. I feel like there can be very strong feelings. And the Heart Rhythm Society, in their consensus statement and their guidance, kind of separated it into two categories: the regulative side, which would be a defibrillation, so you're regulating the heart, and then a substitutive or replacement therapy, which would be a pacemaker. So you're substituting that impulse, which is not present in the native heart. And so some of the opinions and discussion really kind of came down on the fact that discontinuation of pacing, even in someone who is pacer dependent, does not create a new medical problem for this person. This is something that's underlying, it is something that we are kind of artificially supporting with that replacement therapy. Ethically speaking, it is very much equivalent to discontinuing either something like hemodialysis or even mechanical ventilation. But certainly at the end of the day, this needs to be again, a shared decision making, and you do need to respect the patient's wishes and their decisions regarding device management at the end of life. From the patient point of view, certainly the concerns really can be the same, or even the kind of unspoken concerns can be the same as those that are faced by a healthcare provider. Ways to really mitigate some of that anxiety is really to proactively and respectfully prepare for end of life by discussing priorities and goals. Sure, you can explant or take out a pacemaker or ICD, but that's very uncommon, and that would really only be for reasons of infection or something that would be, I guess, where it would need to come out. So most people who have an ICD or a pacemaker die with an ICD or pacemaker. This really should be a team approach, getting everyone involved in terms of not only the clinical team who's treating the patient, but palliative care, support groups, and then making sure that there is good education of the patient and family, as well as everyone else who is involved. And good communication really can ease a lot of these discussions. So the last kind of topic I thought we could talk about today that is certainly relevant is race in cardiovascular care. So the quote earlier from Dr. Joint kind of highlighted some of the issues, but when you really kind of break it down, outcomes for Black Americans are worse. They have the highest rate of coronary heart disease mortality, as well as the highest prevalence of cardiovascular disease risk factors. These would be diabetes, hypertension, hyperlipidemia, obesity, as well as race-related psychological stress. But not only outcomes, but there are disparities in cardiology in both access and quality of care. So there's been a lot of literature and a lot of studies that have come out, and there's evidence that there are actual treatment disparities. Providers and prescribers are adhering less to guidelines, that Black patients get less intensification of their therapy and fewer invasive procedures. Black patients also presenting with MI or acute myocardial infarction are less likely to be admitted to a facility with a cath lab, as well as high quality MI outcomes. And Black patients with MI have lower odds of achieving the goal door to balloon time of 90 minutes. I think really one of the biggest highlights for me was reading that only 1 in 3 cardiologists agreed that racial disparities exist in US cardiac care. And you can't really address an issue if you don't agree that it's there or recognize that it's there. Certainly there are a lot of systemic issues that are way too numerous and too broad reaching to really discuss today, but they include unequal access to resources and opportunities, historical mistreatment and cause for distrust in the healthcare system, and the multiple layers that really affect health, including housing, education, the economy, and the criminal justice system. And certainly the healthcare system itself doesn't really set itself up to take care of everyone equally, and that includes primary care access, insurance, and just access overall to care. But how does that trickle down to something that is relevant on a day-to-day when you're seeing patients or in your clinic? Communication, as well as nonverbal behavior. A lot can be said for the patient-provider relationship and establishing trust. I did some reading on race concordance and kind of the patient-provider dyad and how that does play a role in a trusting relationship. I think in West Virginia, we know that can be really tough. There are certainly areas where white physicians predominate as a very overall white state. However, there are cardiologists, there are primary care physicians who aren't from this country, who are not white, and they take care of very white populations. And so it really works both ways. And patients do have the ethical and legal right to want to choose who their provider is. But on the same token, if that provider is the minority treating a majority white population, they should also have the ability and freedom to react to those preferences if they're stated in a way of malice or an objectionable way. So there's a lot more we could really unpack here, but I also liked this quote, and this is just from a basic ethics textbook, but I thought it really hit home, and it comes to just comes full circle, and the discussion of ethics needs to be multidisciplinary. And it said to please avoid the fallacy that generalization of expertise, assuming the expertise about the technical facts of an area of medicine, give the physician, or substitute whatever provider the expertise and the ethical aspects of decision making in that area. Just because you're at the top of your field clinically or in terms of advancing technologies, that doesn't make you a medical ethics expert. Most organizations and health systems have ethics consultations available, and many times these can be done anonymously by anyone in the organization or anyone caring for a patient who has a concern. So with that, I don't know if anyone has any questions or concerns. Thanks for showing up, guys.
That was excellent, Mary. Thank you so much. That was a really great breakdown of all the ethical components in healthcare. So we really appreciate it. We did get a couple questions in the chat, so I can read it out for you if you'd like that. So the first one is, what would be an indication for discontinuing a pacemaker? besides a patient saying that they want it out?
Yeah, so that's a good question. So truthfully, discontinuing a pacemaker is different than discontinuing the ICD. But if a patient was at end of life and the patient and family were wishing to kind of stop curative therapies, then it would be reasonable to have the discussion about discontinuing the pacemaker function, particularly in a patient who is pacer dependent. I feel like it's one of those areas where it comes along with stopping medications or stopping other invasive therapies or things that were treatments that we're providing.
So, I mean, typically when a patient is end of life and in hospice, we don't actually stop the pacemaker because
Yeah.
we find that the leads, the patient does not respond. The leads don't actually sense anything because the heart is just too sick at that point. And ICD makes sense to actually remove at that point because I believe there's multiple studies. I think you already said this. Multiple studies have been found that patients actually had multiple shocks even at the end of life. So an ICD makes sense. I was just curious as to the pacemaker.
Yeah, and I can't say that I've ever been a part of a situation where we have deactivated somebody's pacemaker or even necessarily recommended it for any type of comfort reason. Certainly that wouldn't be the case, but I think in certain situations, I think it would be reasonable to talk about, but certainly doesn't have kind of the negative effects that an ICD shock would have at end of life. And you're right, at a certain point, you don't capture anyway, just because of all the metabolic issues that happen.
Yeah, my other question really was on the whole ICD and DNR, because if somebody is DNR, doesn't it make sense to have the ICD off as well?
To have it on or implanted?
Off.
Yeah, so I think that, I think that's the time when the conversation has to go hand in hand. And if you're talking about resuscitation and traditional resuscitation with external pads, a shock would be part of that. So talking about the shock from the ICD when you talk about resuscitation status would be the appropriate time to do that, in my opinion. And I think that goes along with kind of informed decision making about that.
So I mean, as somebody who works like deep in cardiology on this, how does this conversation usually go, and what is the usual thought with regards to all of this? Because I often get patients who transfer my service for whatever reason, and they are DNR, but the ICD is still on, and I'm having to call cardiology to be like, all right, can we address this and get it off?
Mm-hmm. Do you know if they've had the conversation up front about the ICD specifically?
Well, I'm not even entirely sure, and usually know at that point. So I was just trying to get a sense of, from a cardiologist perspective, what is the general consensus of what usually happens with you guys when you're faced with this situation? Because for me, it's usually very simple. Like I deal with this all the time. So I'm just like, all right, can we just turn this off? But for you guys, I don't know the actual thought process or anything.
No, I don't think it's any different, to be honest.
Let's see. All right. Okay. Cool. Thank you.
Yeah.
Awesome. Any other questions or thoughts, comments?
Donna, do you work in primary care? I'm sorry, I didn't hear your introduction.
With population health, and our team, I'm a disease management coordinator. So what we do is we have a select group of patients that we pull from, like and our patients, for instance. And if they have certain requirements, usually they have to have a primary disease like CHF, diabetes, COPD, something like that. And we started when 2 years, 3 years ago, there were 5 of us. Now there's like 25 of us. So they're all over the state, and it is, helping the coordinated care for patients. So hearing your suggestions and watching what the doctors want and kind of supporting that with the patient, making sure they understand, making sure you try to keep them from readmitting. That's the big thing. And just giving them the services to them coordinate their care.
Cool.
Awesome. Well, thank you so much, Mary. We really appreciate it. And we do post our sessions onto our YouTube page, and I always check that out. And we always get a lot of views after the fact as well. So we really appreciate it. Thank you so much.
Okay.
If there are no other comments or questions, I do just have a couple announcements before we part ways. So our next session will be on August 7th, and Jennifer Thomas Chrissy will be providing our didactic then. And the last thing is Zoom is supposedly requiring us to create a password now for our meetings. So if that is in fact something that's going to be incorporated, I'll get more information on that and send that all out to you guys. So don't worry about that too much. I just wanted to make a brief announcement. But okay, thank you all so much. We'll see you guys next time. Thank you.
Thank you, Mary. That was very nice.
Thank you.
Thank you.